June 12th meeting of the HERC is called to order. And then Daphne, is Daphne doing roll call or Jessica?
Daphne.
Okay, Daphne, do you want to call roll?
I sure
Daphne,
do.
can you open the recording, please?
I already did. Thank you for the reminder. Thank you so
Sorry,
much.
I did not hear that. Okay.
Mark Buckholz.
Present.
Thank you so much. Mike
You're welcome.
Collins.
Do not see Mike.
Thank you. Stacy Geisler, I have as absent, as well as Ben Hoffman. Max Kaiser.
Here.
Lisa Kouzes.
Here.
Linnea Lindsay.
Here.
Lawrence Lyon.
I am here.
I list Chris Benzon as absent, as well as Katie Shavel. Leslie Sutton.
Here.
Adrian Irwin.
Here.
And I see that Devin Consagra is also absent. We have quorum. Thank you very much.
We will start first with the orientation presentation.
All right, welcome everyone to the Health Evidence Review Commission. Decisions made here will affect about 1.3 million Oregonians. And these decisions are about coverage for under the Oregon Health Plan. Also, these decisions will affect people's families, caregivers, and providers. We will not be making any decisions about individual care here today. We will also be hearing public comment in a little bit. Decisions made here will be implemented at later dates. In some cases, it'll be as soon as October. In other cases, they'll wait until January 1st, 2027. Those are the changes related to the benefit update project. In general, we're looking at considering factors including the assessment of the balance of benefits and harms based on the evidence, expert guidelines, and so forth, patient values and preferences, stewardship of public resources, and just the nature of the delivery system, the limitations we face in Oregon. Members, please do your best to be on camera and attentive. Again, message Daphne if you step away so we can keep track of whether we have quorum in real time. We will be doing our votes by roll call, and speak up or raise your hand. Please do not use the chat for discussion related to the meeting. It just keeps, some people might not see the chat and we want to have one discussion here. So just raise your hand or just speak up if you have something to say. Other participants, those offering verbal testimony, please make sure your Zoom name matches your registration name that you used when you filled out the survey. Anyone else can use the Q&A feature. Those things put in the chat or the Q&A are part of the public record, and the recording of this meeting will be posted on YouTube for posterity. Next slide. And anything else we can't address during the meeting, if we're not able to get to your question and answer, please send us an email at this address, herc.info@oha.oregon.gov, and we will get back to you once we are out of the heat of the moment. So that is our orientation.
Thank you, Jason. So at this moment, before we discuss the matters on the agenda, this is an opportunity for any committee members to disclose any conflicts of interest related to today's topics. Seeing none, I will turn it back over to Jason for director's report, as well as an update on the status of the minutes from the last meeting.
Spoiler alert, there are no minutes. We have not been able to get to those due to our meeting schedule. They're almost done. They will be posted in draft form on the website soon, and then we will vote on them along with today's minutes in August. The VBBS minutes are posted, and those do contain the decisions made at HERC at the last May meeting. So the crucial information is there, but the formal minutes have not been completed yet. In other news, we had a listening session scheduled for yesterday evening. That was canceled due to lack of participation. I think we had some people reach out, but their problems were better addressed elsewhere, and Daphne helped them find other venues. There's also a legislature in Salem. There are several bills pending in the legislature which would affect our work. However, they are in the Joint Ways and Means Subcommittee. There are some tighter than expected budget situations, and we do not know whether any of those will move at this point. Also wanted to mention, we had reviewed the decision standards document at the retreat. I'd hoped to bring it back today, but due to the coverage guidance and everything else, we're going to attempt to bring that in August as well. We also are starting something new on Monday, and this is a technical office hours. This is about the file format. So this is not about anything political that you'll discuss today. This is not about the big picture policy of the benefit update project. It's just about assuming that the benefit update project goes as we have been planning, how will the actual data files change? So this will be of interest mostly to IT professionals or people with administrative systems related to the prioritized list. If you know such a person, please recommend that they attend and send us any questions they have if they're able, so they can let us know. So this is something new we're going to try. I don't know whether anybody will come or what questions they will ask, but we want to make ourselves available to minimize the chance that there will be systems problems with the benefit update project. And that is the staff. Oh, sorry, I wanted to add to recruitment. Thank you, those of you who referred people as possible or subcommittee members. We had some great applicants. We're reviewing those now. We'll be submitting recommendations to the governor's office. We won't be able to say much more than that until they're proposed to the Senate, but and those positions are technically still open. So I wouldn't, if you have others that you think might be interested, again, we're looking for a consumer rep, a pharmacist, and a behavioral health rep. And we do have some applicants that appear strong for each of those, but we have not closed the application process. Looks like Daphne has something to add.
Yes, thank you, Jason. I did want to mention that Jason did say that we canceled the listening session and we referred people to places that could help them, but we also were contacted by a provider whose issue could be addressed more quickly than through a listening session. And so I think you're going to hear about that today. Just wanted to mention that. Thank you.
Yeah, we actually heard from her this morning and it was great. Good discussion. All right.
Any questions from the commissioners? Okay. So this brings us to public comment for items not on the agenda. Daphne, do we have Mr. Turdal here?
Mr. Turdal is here. Mr. Turdal, I'm going to promote you to panelist.
Thank you. Can you hear me okay?
I can. If you'd like to be on camera, I can put you as a panelist. Would you like to be on camera today?
That would be fine if that works.
It does. One moment. It'll take a second for you to change positions. Okay. One moment, please. The Health Evidence Review Commission welcomes and appreciates public testimony. We understand it is an important consideration for our work and will listen with attention and respect. Although members may not discuss the comment right now, staff and leadership will discuss it prior to the next meeting. As a reminder, the Commission does not decide whether particular services should be covered for an individual patient based on their individual circumstances, but staff can help connect OHP members with helpful resources. Each speaker is given 3 minutes, and it looks like we have one. To keep us on time, we'll start a timer, and that will be shared on the screen. So please conclude the presentation when the timer ends. And you may begin, Mr. Turdal.
Thank you very much. So again, my name is Paul Turdal. I'm a volunteer health consumer advocate for individuals with autism and other disabilities and the father of some Medicaid eligible children. I want to briefly follow up on previous testimony regarding my request for a medical technology assessment of gender affirming treatment. I provided a pretty lengthy written statement, so I'll just refer you to that. There are a couple of key points that I wanted to point out. In the last meeting I testified in January, there was discussion about what the criteria might be to bring an issue back for consideration, and the feedback essentially was if there was substantial new evidence. And what I have done in my written testimony is I provided you with a very long list of pretty new systematic reviews that have really come out just in the last 2 years since this was last up for consideration. So there is a lot of new evidence. I am concerned that the evidence generally is expressing, the systematic reviews are generally expressing concern about the quality of evidence for benefit, and I think you should look at that. The other thing I wanted to point out, in a lot of the feedback I have heard is that you are reluctant to work on this issue because the legislature has essentially preempted your authority by passing House Bill 2002 a couple of years ago. And thus, even if you were to do something, maybe you wouldn't have a policy, role in it. I think you need to take another look at that. Specifically, Medicaid or Oregon Health Plan is governed by the 11 and 15 waiver. That waiver clearly specifies that this commission is responsible for making decisions about the prioritized list based on evidence of clinical effectiveness and cost effectiveness and public input. I am concerned, given the national political environment, that in doing this the way you have done it, and making that argument that this was legislatively mandated and you've lost authority, is that we may have violated the terms of our Medicaid waiver. That waiver does have a termination clause, and I am just concerned that because of the way this is doing the political environment, that there's a risk the entire waiver could just be terminated. If you believe you do have good evidence in support of gender affirming care, it would really be helpful for you to do that study, do that work, do that evidence-based guideline, and basically show and document the evidence you have to support this. There was an HHS report out a month ago, basically finding very poor quality evidence. That was actually not inconsistent with the OHSU report from a couple of years ago that was canceled. But if you think you've got better evidence, it would really, really be helpful to put it out there and basically say, hey, we've done our work, we found good evidence, here's what it is, and here's why we should continue doing it. Thank you.
Thank you, Mr. Triddall. I'm going to kind of hand this over to Jason to provide a couple of comments.
Yeah, I'll just say thank you for that, Mr. Triddall. I know our OHA leadership is reviewing federal guidance and monitoring the waiver and are aware of many of the issues you raised. So thank you for that testimony.
Thank you.
Are there any other comments from the commissioners for Mr. Triddall? Okay. Thank you so much for your time and coming to speak with us again today. With that, we will transition it over to the VBBS subcommittee report.
Great. So the VBBS met this morning. We had a very full agenda, which we're not able to get all the way through, which is just fine. VBS members should feel great about what they did get through. So we had our usual consent agenda that was approved without any discussion. We talked about hypersomnia, and the recommendation is to add coverage. And this would basically move it up to the sleep disorders line and change the name of that line to include hypersomnia to clarify that that is our coverage intent. And so you'll see on the screen, there's certain ICD-10 codes, adding those to the covered sleep line and removing them from the non-covered sleep line and then changing the name of that line to include hypersomnia. We talked about insomnia. There was a proposal from staff to modify the current insomnia guideline to allow a 30-day treatment with medications, not only if a patient is currently in kind of behavioral therapy and for insomnia to it in the past, but also if it wasn't available based on testimony that we have availability for providers that speak the correct language, access through poor internet, not having the medical literacy to do like the apps, that type of thing. However, the group this morning was very concerned about not at least requiring some pieces of the CBTI, such as sleep restriction or improved sleep hygiene, and staff were directed to work with our sleep expert to further try to clarify that we do want some type of therapy for sleep to be done, and also to work with our pharmacy and therapeutics colleagues about the current wording that restricts medications to 30 days and whether we should carve out some of the newer medications that have a better safety profile. So that was tabled. You will not be voting on that decision. Just brought it up in case there's any questions or anyone wants additional work on that area. We talked about nitrous oxide for non-labor indications. This was approved. We made one friendly amendment to what was in your meeting materials. The current guideline that's attached to a line would become an ancillary guideline. And it would just clarify that we cover nitrous oxide for labor and medical and dental procedures. We do think you need to continue to have a guideline because there are no standard billing codes. So this just kind of makes it clear that we want this covered. We then talked about cognitive behavioral therapy for migraine headaches, and we heard testimony from a patient and mother of a patient who had great benefit from this treatment. However, the VBS members this morning felt that if the migraines are causing a mental health disorder such as adjustment disorder or anxiety, depression, the patient would have access to CBT, and that the evidence didn't support CBT for migraines alone without behavioral disorders. So no change was recommended to the prioritized list. Our last new discussion item was lipoma removal. Lipoma are benign fatty growths. They are very common right under the skin. They can be in deeper areas of the body. The staff recommendation was to add coverage with a new guideline that would restrict coverage to a certain size or rapidly growing or abnormal appearance on imaging or problems with function. However, the group this morning felt that if a mass was rapidly growing or had abnormal imaging, it wasn't a lipoma and should be removed and used as just a mass code for a diagnostic excision, and that the pain and function issues are better taken care of through the exception process. So only one piece of the recommendation was approved, and that was adding one of the deeper types of lipoma that involve genitourinary organs to the kidney urinary lines to comply with a different kidney lipoma code that's already there. Any questions about these new discussion items, or anyone want me to have any other thoughts on insomnia before we bring that back to you at a later date?
I had one question on the CBT migraine. Is that the one that the physician was going to speak about?
Yes, thank you for reminding me about that. Do we have the physician speak? Is she here today or at this time?
Oh, that's right.
Dr. Green.
Dr. Green was going to come. She is not here. Maybe we should come back to that topic if she arrives later.
I would like that.
Did you hear that, Ariel?
Yes. Or we can, when we get through the VBS report, if you want to approve it and she comes later, we can always bring that back up, however you want to handle that.
That's fine.
Okay. So the other topics that we discussed was vitamin D testing. I had been asked to look at the evidence about vitamin D testing and repletion before elective surgeries. The evidence actually doesn't show that repletion of vitamin D is helpful, although low vitamin D is associated with poor outcomes. But adding back the vitamin D doesn't help, so it may just
Page
be
114 of the packet.
it may just be a marker for something else. I was also directed to look at the evidence for mental health related issues with vitamin D. There is an association of low vitamin D with various mental health issues. However, the evidence doesn't show that, again, repletion of vitamin D is helpful. My personal interpretation, this is not an expert interpretation, but my medical interpretation is that low vitamin D may be correlated with something else, like lack of exercise or poorer diet, and that's what's being reflected. But it doesn't appear that testing and treatment is actually going to affect the long-term outcome that we want to affect. So the recommendation from your BBBS is to approve the guideline as was written in your meeting materials, which would have a guideline that would further restrict the types of diagnosis codes that could be allowable for pairing with vitamin D testing. There was also some code movements because of lack of needed codes on certain lines or availability of codes that needed to be paired on other lines. So there's a little bit of code changes. The main thing is the guideline note here that kind of fine tunes when we would cover vitamin D testing. There is your hand up.
Was there, what type of review was done? Did staff, I'm assuming that staff did a review of mental health outcomes with relationship to vitamin D and specifically vitamin D deficiency. Is that anywhere around here?
So I did not provide any materials about, there is an extensive literature that shows that low vitamin D levels are associated with
Yes.
depression, worsening outcomes with psychosis, etc. But when you look at the literature about replacing the vitamin D and bringing the vitamin D levels back to normal, it doesn't impact at all any of the outcomes. So
Because
vitamin D is a marker for something else is how I would read that.
Because what I'm reading, deficiency in vitamin D linked to increased risk of depression, ADHD, anxiety, and suicide with supplementation showing potential benefits, but I'm not sure if
The
this is
literature does not show that. There was one randomized controlled trial that found people with normal vitamin D levels who were supplemented to super therapeutic levels had a slight improvement in their depression scores. That's the only the people with low vitamin D levels who were supplemented to normal levels did not have any effect.
Maybe normal.
Leslie?
I just wanted to see if Dr. Schabel was at VBBS this morning. I know that this was a topic that she had a lot of input on.
You know, and I had provided her with all this material ahead of the meeting, and I did not receive any comments back from her. I tried to get her in.
Great, thank you.
I would love to see more evidence on this. And I can only speak anecdotally on this because I have seen some significant improvements in behavior and depression with supplementation of vitamin D. So additionally, vitamin D supplementation is cheap. The test is not so cheap. I'd love to hear what others think about this.
So while people are mulling, maybe I'll provide a little bit of flavor from this morning. There was some discussion this morning about how testing and supplementation has, in some spaces, become really common, which is, I think, what you're referring to. So there's some discussion about what do the CCO medical directors and where did some of this come from. And Ariel, maybe you'll can provide some context for how this was identified as an area of interest for Oregon stakeholders specifically.
Yeah, so this was identified nationally. Many national groups have identified this as an area of high medical waste, that there is a lot of vitamin D testing going on and it hasn't improved any health outcomes. The AHRQ did a review that came out a couple years ago looking at vitamin D and didn't find that replacement improved any outcomes. They looked at a wide variety, mortality, falls, fractures, all kinds of things. They didn't find any benefit from screening. I'm sorry, I misspoke. So there may be a, they didn't look at supplementation, they looked at screening itself. So it's been shown by our trusted evidence sources that screening has not been beneficial. There have been separate evidence reviews by several other, large organizations, Choosing Wisely, and Medicare and private insurance have been really coming down and very much restricting this in the last few years. Any of us who practice with there's an electronic health system, there's many things that will pop up if you try to order vitamin D. It's allowed only for things that are osteoporosis where bisphosphonates don't work if you don't have enough calcium and vitamin D, that kind of thing.
Yes, you're absolutely right. Medicare does have very strict requirements for vitamin D
Yeah.
testing. Yeah.
And
Yep.
that's been echoed by private payers, and our current coverage would basically echo them as well. So we're kind of trailing in this field, not leading. Additionally, the Oregon Health Leadership Council, the reason this first came to our attention in 2019 was the Oregon Health Leadership Council came out and said this was a high area of medical waste in Oregon, and we should stop doing it. And so initially we had it had been diagnostic, we put it on lines to try to kind of limit the use, but now we're still seeing that on those lines there's thousands of diagnoses, so we're limiting it further to the specific diagnoses that we were
Okay.
should be allowed.
Thank you. Yep. Thank you.
And Ariel, spot on, wanted to second that. At Pacific Source, we looked at other insurance companies, and very few, if any, cover this for screening public health. And we have now limited it to the pairing diagnosis and what other insurance companies cover it for. So we were behind the eight ball on this one, but I think we're catching up.
Yeah, and I shared this guideline with the CCO medical director group and got their input. They were all strongly in favor of it.
Any additional questions, Dr. Berkholtz, or is that just a hand up for the moment?
I'm sorry, that's just a hand up. I'll put it down. And my PCP said just take vitamin D.
Just screening necessary. Okay, any other, questions from the group about this topic? Okay. Ariel, I think you can continue.
All right. So then we also talked about cervical spine manipulation, and we had the pleasure of having several experts who testified
Page 121.
about the safety of cervical spine manipulation. I know at our last meeting, or maybe it was in March at this group, we had a pretty in-depth discussion where there was a lot of concern about cervical spine, chiropractic, osteopathic, the manipulation of the neck, causing dissection of the vertebral arteries, the main blood flow up to the back of the brain, causing stroke. And our experts who testified today talked about there is a relationship between neck pain and headache and subsequent the strokes from basilar artery, the vertebral artery dissection. But it's never been shown that the neck manipulation is associated with it. So it may be people seek chiropractic or osteopathic care because they're already having neck or headache from something that would predispose them to having this kind of dissection, and that it's not necessarily a cause. It may be a extremely rare adverse event, but it doesn't seem to be based on the literature. So the recommendation is essentially what you saw in March, which was to, and this is for the BUP process. It would add the chiropractic osteopathic manipulation to the migraine tension headache code grouping, and it would have a guideline, which is our current cervicogenic headache guideline. What was approved in March at VBS, and that was bringing back to you because you didn't approve it, was that cervicogenic headache would be covered, or chiropractic manipulation would be covered for cervicogenic headache only on that. So in the code grouping, only cervicogenic headache is covered. We don't currently cover these manipulations for migraine or tension headaches. There's no evidence there. And then additionally, actually, Liz, if you could just page down just a teeny bit. There was a little bit of additional wording based on the discussion here that we would put a limit of 30 visits of manipulation a year. That is consistent with our back pain guideline. And then just a clarification that the cervicogenic headache in this code grouping doesn't pair with massage or acupuncture, which is also in the code grouping. So just kind of housekeeping kinds of changes, except for the visit limitation. And that our Lisa Kuzis, who's a member here, also spoke. So she can, I'm sure, answer any questions if anyone has any questions or concerns there.
In addition, I think we have an expert on the line. Is that correct?
Yeah, Dr. Daniel.
That is correct, Dr. Daniels. One moment, please, while I make you while I change your stats.
Is there any discussion from the commission before Dr. Daniels speaks?
And I just wanted to mention that Linnea Lindsay has stepped away, so no votes.
I thought we were at one extra person.
We were gonna be, but
Oh, we're
we
gonna be.
lost one.
We lost one. Oh, okay.
All right, Dr. Daniels, one moment, please.
That's good. Good afternoon, everybody.
This topic may be a sensitive discussion for some. As a reminder, PERC's a policy-making body and can't make decisions about coverage for care for individuals. Any policy changes resulting from today's discussion will go into effect at a future date. This discussion may be intensely personal for some, yet in this forum, we tend to discuss subjects in terms that seem clinical and impersonal. And not every person's experience will fit into the picture that the clinical evidence shows. Please be aware that our commission's business is to make the best possible decisions for the general population, using the commission's methodology and processes to determine the importance of services. So today, there'll be 3 minutes for you, Dr. Daniels, and you have a presentation. So we'll let you know when the 3 minutes is up. Please begin, of course, by stating your name and any potential conflicts of interest you have regarding this topic. And you may begin.
I appreciate it. I'm Dr. Clint Daniels. No, not paid to be here. No conflicts of interest. I am the chiropractic section chief and resident director for VA Puget Sound Healthcare System. So I'm essentially in charge of all the chiropractors that work in VA in Western Washington. And we treat patients with tension type and migraine and cervicogenic headache every day in our clinics. I'm also affiliate assistant professor for rehab medicine at University of Washington, which is a research appointment. I am chair of the Scientific Commission for Clinical Compass, which is a nonprofit that makes best practices for the chiropractic profession. And I serve on the Washington State Health Technology Clinical Committee, which is our equivalent of the HERC, where I'm the lone chiropractor on that committee. And so, I said this morning, but I really understand firsthand how hard it is to make these, evidence-based determinations. And I always appreciate caution being given to any topic that involves patient safety. And, in my opinion, this is actually a pretty easy topic from an evidence standpoint. It's been studied a lot, and I think the evidence is really clear. So that's what I'm going to talk about here briefly. Next slide, please. All right, so cervical spine manipulation has had more than 200 randomized controlled trials performed. Not a single one has ever identified a study-related serious adverse event. And when we're talking about serious adverse events for spinal manipulation or cervical manipulation, we're really talking about arterial dissection, as that's the only real condition that's been sort of theorized to have some relationship. So randomized controlled trials are also underpowered to detect rare events. So the best evidence that should be relied on for these determinations is looking at population-based studies, case controls, things like that. And there's a lot of these studies as well. Next slide, please. And they exist in a lot of different populations. So we've got it in really large Medicare data sets. Next slide. In private payer, commercial insurance data as well. Next slide. In academic hospital data. Next slide. And also in the entire country of Canada. And so, sort of irrespective of which population was chosen, these studies really have the same outcome or result that they report. So next slide. And that's essentially that cervical arterial dissection is very rare. It takes millions of patient years worth of data to even detect a signal. And that the risk following chiropractic is essentially equivalent to the risk following senior primary care, which is to say that there's really a minimal risk and it's unlikely to be causative. There is the association though, but again, equals the association of going to the primary care, which lends to the theory that Smits said earlier. Next slide. And so I'll just leave you guys with, covering cervical spine manipulation for Oregonians with headaches is evidence-based. It is patient-centered, and it's also equitable. And thank you for your time, and I'm happy to stay on if there's any questions.
Thank you so much, Dr. Daniels. Any questions from any of the commissioners? Let's go for it. Else to say, Dr.
I'll just add, so the other expert that we had this morning, and unfortunately his schedule did not work to speak to us during the afternoon, was Dr. Walter Herzog. So he is not a chiropractor, but he's a biomechanist, and he testified that he spent the past 40 years studying the mechanics of chiropractic adjustments, and answering key questions like this for the profession and for just the population. And so he has used animal models, cadaver models, living human models. They've looked at the tension of the cervical arteries with adjustments, with activities of daily living, but he said range of motion, so with range of motion. They've looked at pressure changes. They've looked at blood flow change. I don't think he said that, but I just also know that. And he described that there is some slack in the arteries that allow the arteries to move before they even reach tension. And one of his major conclusions was that the chiropractic adjustment does not rise to the level of any tension or any mechanical stress on the arteries compared to end range of motion. I believe he said about 50%. So 50% of the mechanical tension on the arteries from the chiropractic adjustment is compared to the end range of motion. And he flatly said that this mechanism does not support the causation, a stroke or a cervical dissection being caused by the adjustment. So I just wanted to add that. And then one thing that I added, which I would also like this group to know, is in the CDC's 2022 opioid pain guidance, under recommendation 2 is literally chiropractic care for tension headaches. So here they're recommending that instead of pain medicine. And I've also done looking at some evidence as far as and had some support. Other people have found some evidence for me about the relative risks of medical management with NSAIDs and that kind of thing, and the risks of those involved versus chiropractic care. So if anyone's interested.
I have a quick question.
Dr. Lyon, go ahead.
Yeah. On the previous page or slide, Dr. Daniels, can you go back to, you mentioned that chiropractic care for cervicogenic headache was evidence-based, and then I believe it also said patient-centered and equitable. And just for a point of clarification, what do you mean by patient-centered and equitable?
Sure. Yeah, great question. So first, regarding patient-centered, essentially, the way we treat it here in the VA is it's sort of up to the patients to decide which treatment that they would like to pursue when there's sort of multiple effective treatments available. So some people are responders to spinal manipulation and will prefer that. Some people are responders to Botox and will want that for their migraines. Some will prefer acupuncture. So the patient should have some autonomy in this as well. So that's sort of what I meant by patient-centered, or medication, or.
So it's, if I understand you correctly, the patients who are selecting chiropractic care is a self-selected group. Is that a fair statement?
I mean, it depends on the setting. In VA, all of our patients are from referral. So all of our patients come to us from, neurology, neurosurgery, primary care, different specialties. But, there will be patients who just prefer a certain treatment over another. And so I would say the same is true for back pain and for other things too. Some of our patients want to see us, some prefer to see physical therapy, some I think it's good to have options for them
Yes,
for things that are effective. Yep.
No, I'm not questioning that. I'm just remarking that the patients who are choosing this, they are essentially self-selecting for a particular avenue of care.
Yeah, I would say, yeah, for some of them, that's definitely true. Yep. And then regarding the equitable, which was, I think, the latter portion of your question, complementary and integrative health services, chiropractic, acupuncture, massage, are typically seen or treated as sort of a luxury when it comes to payer systems. And people of means, people with money, seek these a lot. And we see it in our studies where they're not representative of populations, because they're commonly not covered. So people with lower means can't seek them and then seek out other things that are maybe less effective or more risky, opioid medications, things like that. So that's what I meant by more equitable.
So in the VA system, having chiropractic available creates a more equitable system where people are free to make choice, not based on money. Is that a fair statement?
Yep.
Okay,
that is true.
Great. Thank you.
You're welcome.
Any other questions? And I think specifically,
I have a question. I know for back pain, chiropractic care generally peaks at 12 visits in some studies. What's the data that requires 30 visits for cervicogenic headaches? Can it be less than 30?
Sure, yeah.
That
Can we
number
limit it to 12?
back pain guideline. It wasn't based on any standard medical.
And that's a combined limit for acupuncture, chiropractic, and osteopathic and physical therapy. So it wouldn't necessarily be that somebody would get 30 just for this, but the clinical question remains.
So let me understand the question just a little bit more. Because I heard an answer a little bit about this neck and back pain in general, and that there wasn't necessarily a medical reasoning or rationale behind visit limits. Are you asking about for just neck and back pain, or is this which page?
I'm looking at this current one on guideline note 218 for up to 30 treatments a year. What is the data that requires up to 30 treatments a year? And is there evidence that more than 12 treatments are needed? So the question is, what is the data for up to 30 treatments a year chiropractic care for cervicogenic headache?
And I think the answer is that is the current benefit. Is that true? And that it comes with other.
Yeah, actually, let me clarify. Sorry. Ariel, tell me if I have this wrong. So there is a combined limit for pain of the back and neck, and that is for physical therapy, occupational therapy, acupuncture, spinal manipulation. This limit is also 30 treatments, but it is separate. Is that correct, Ariel? It is not combined with the guidelines.
The initial staff proposal didn't have any limits. I was asked at the March meeting to at least do 30 treatments, because in the back guideline, if you had chosen to do, it's a combination of chiropractic, acupuncture, and massage, but if you had chosen only to do chiropractic, you could have up to 30 treatments. So it would be in line with that.
So if they decided to make it 12 or whatever other number, it wouldn't cause problems with that guideline, because this is a totally separate limit.
Exactly.
Okay.
But I understand that someone could have 30 visits for neck pain and then an additional 30 visits for cervicogenic headache. Could that mean 60 chiropractic visits a year, or is there a?
That's correct. It is 30 a year.
Interesting. I would love to hear from Dr. Daniels about just his opinions, or what kind of references he may have to answer that question. I believe he has something regarding, some clinical evidence for visits and visit frequency.
Yes. So just up front, I don't endorse 60 visits a year, just to clarify that.
Yeah.
There's relatively limited dose data available. Dr. Buckles brought up one on 12 visits, which I think was a low back pain dose response study. There is one on cervicogenic headache that was done by the same team, actually, out of the University of Minnesota. They were actually in Portland. They were at Western States. They found 18 visits for cervicogenic headache, and I can find that reference here in a second. They did essentially the same design, though. They compared 6 visits, 12 visits, 18 visits in that study. And in the low back one, the people who hit 12 visits then sort of plateaued. In 18, they continued to see visits, in the headache one, they continued to see improvement to the 18 point. 18 starts to already be quite a few sessions, though. So I don't know how much further, like if they had added on 24, I don't know if it would have continued to go up or started to level off at that point. But we don't really have the data beyond 18 visits. Do you agree with that, Lisa? Have you seen anything else?
I think you're going to be the expert on the cervicogenic headache part. Yeah. I have, so I can speak for at least just the standard of care in Oregon. So in general, there's like a 4 to 6 treatment, trial. So if there's no improvement, and this is kind of broad strokes, if there's no improvement after 4 to 6 treatments or 6 weeks, that kind of thing, then the treatment's not really working. And so, but if there is improvement, then continue. And it's like reevaluate again in 4 to 6 treatments. So that standard is utilized in our practice. And so I have reason to trust that chiropractors aren't going to just use what the limit is. I mean, I know there's outliers, but that is the standard that's already in place.
I do want to comment, that is the standard within your group. I would say from our data, that is not the standard among all groups. And if we could have a limit to what is medically, scientifically proven, would be helpful from our standpoint. We have noticed that some providers may provide services up to the limit and adjust their treatments based on a patient's benefit limit. And that's why looking at what has been scientifically proven would be most helpful from the insurance standpoint to provide the best quality care.
So I'm going to try to keep, I think, this conversation moving, because I was not here in March, but my understanding was this conversation came back because there were questions about the safety profiles. I am not hearing any concern today that's related to the safety of this. It seems like maybe the conversation has evolved into what the appropriate treatment number is. At first, I guess, want to see if there's any comments related to the safety component. Are there any questions on the safety component, since it seemed like that was where the conversation left in March? Okay. So from there, I guess the question, and maybe Ariel or Jason, you can comment, do you have a recommendation in terms of whether it makes sense to go back to literature and to see if that 30 treatments is something that we should explore, or is there a time sensitivity to needing to do this today?
No, this is a BUP change, so we have quite a bit of time. If we want to bring that back, I'm not hearing any general concerns. I'm just hearing concerns about the 30 visit, correct?
That is all I'm hearing, but I want to provide an opportunity for the commissioners to provide, I think, any other places that we need to do a little bit more investigation to get to a point where everyone is comfortable and able to feel like they can vote. Or do people feel like they can vote today, but we're really razor thin on quorum to begin with? And so if it doesn't seem like we're in a consensus spot, it seems like this might be an item for table and bring back in the future with a really narrow spectrum of what the outstanding question is. Nobody's jumping off mute, so I'm not seeing that anybody really wants to vote. So yes, go ahead, Dr. Lyons.
Quick question.
Yes.
So I'm looking at the reference that was put in the chat. And then I'm also thinking back to just a few minutes ago, the 30 visits, for cervicogenic headache was separate from the 30 visits total sum of acupuncture, physical therapy, massage therapy, chiropractic treatments. Is that correct?
Yes, that's correct. I misspoke earlier.
Okay. So the 30 visits for the headache, that's 30 visits for headache, cervicogenic headache alone. I think that this bears further discussion, especially in light of the reference that was put into the chat.
Okay, so if we were to table this, and I'll punt to Ariel or Jason in terms of from a time or procedure, and I'll let the group take the conversation a different direction. What I am hearing is I'm hearing a desire to table this conversation, or it seems like we're not in a position that we're ready to take a vote on it today. Ariel will look for any type of data that would support 30 treatments a year or potentially a different number, and then we will bring it back at the next meeting with a much more, with that being the lingering issue. Does that seem like a reasonable direction?
Yeah, so in my notes, I'm saying you're sending this back to VBS. You would like me to look at additional evidence, and hopefully, Dr. Daniels, you can be helpful if I could reach out to you to look for evidence regarding sort of the number of visits needed for response for cervicogenic headache, and bring back wording changes or not, depending on what we find in the visit number. But otherwise, it would be limited to just that. Everything else would be sort of agreed upon as that. As okay.
Any other points from the group, since we're sending Ariel back into literature to address outstanding questions? Okay. Do I need to vote to table something?
No.
Okay, so we will, should I go to Dr. Green?
Yeah,
Okay.
so we can move on to the.
Okay, so we are going to pop back up onto the top of the agenda. We have a guest here, Dr. Green, who is going to provide some testimony on an earlier topic related to the use of CBT in migraine treatment.
Hi everyone, thank you so much for having me and for your patience. I'm sorry I was late and it's been a long day, and I really appreciate all of your thoughtfulness in considering the evidence for this really important treatment. So I'm a pediatric headache specialist, a pediatric neurologist and headache specialist at OHSU Dornbecker Children's Hospital. So this is an issue that's really important to me professionally and personally. Migraine, we know, is really common in children and adolescents, and I will back up and say I'm going to speak largely to the use of cognitive behavioral therapy for migraine in children and adolescents, because that's the topic I'm most familiar with, although I think it's well supported in the adult population as well. Migraine affects about 8% of children and adolescents. That's like 1 or 2 children in every elementary school classroom, and can be a cause of significant disability. We know that children with migraine miss more school and perform more poorly in school than their peers without migraine, and have significantly lower scores on quality of life measures. So it really highlights the need for effective treatment options in this population. But unfortunately, we're sort of operating in an evidence-free landscape in the world of pediatric migraine. There's really limited evidence for effectiveness of traditional migraine preventive pill-based treatments. The largest study looking at this compared topiramate, amitriptyline, and placebo, topiramate and amitriptyline being the most commonly used preventive medications, and found that there was no significant benefit compared to placebo using those medications in this population. The most recent guidelines we have from this is from 2019 from the American Academy of Neurology and the American Headache Society. And in that guideline, they evaluated all of the evidence for preventive treatment for migraine in children and adolescents. And the highest level of effectiveness is for the combination of amitriptyline and cognitive behavioral therapy. That's based on a study that compared amitriptyline plus cognitive behavioral therapy to amitriptyline plus education, standard education, and found that the cognitive behavioral therapy piece resulted in a significant reduction in headache frequency and headache-associated disability. And that's also supported by a 2017 systematic review and meta-analysis that also showed that CBT was effective in reducing headache frequency and disability in children and adolescents. So based on both the evidence for effectiveness, but also to some extent the positive evidence for other interventions in children and adolescents with migraine, I really feel strongly that this is an essential component of treatment of migraine in children and adolescents. I'm fortunate in that we have a headache psychologist incorporated into our headache clinic at OHSU who sees many of our patients with migraine. I believe that, to my understanding, the current policy allows for cognitive behavioral therapy in patients with migraine if they also have an alternative diagnosis like anxiety or adjustment disorder. But the truth is that I would recommend this type of treatment to any child with migraine, whether or not they have comorbid anxiety, mood disorder, adjustment disorder, et cetera, because the cognitive behavioral therapy piece is aimed at the migraine problem, not the comorbidities, because it seems to be effective in reducing headache days. I believe the group this morning also heard from one of my patients, and just anecdotally, I have seen this be a life-changing therapeutic intervention for my patients, and I would strongly advocate that it be covered. Thank you.
Well,
I'm happy to answer questions.
Thank you so much for being here. And Liz, do you mind putting her staff recommendation for this topic up on the screen, that we were all on the same page in terms of the topic that we're talking about?
Yeah. Sorry, I was thinking, but yes, it's good.
Yeah, so just to orient the group, we're kind of going back onto one of the first items that was discussed, and this is related to CBT for migraine. So just to reframe, and I'll give kind of a moment to pause, and then Dr. Lyon, I'll take your question, but I just want to make sure everybody's kind of on the same page for the topic that we're talking about, and we're able to kind of contextualize the testimony that we've heard.
And can you remind us what page we're on? What page of the VBS?
Daphne, do you know what page we're?
103 is the beginning.
Thank you. I have a question. Can anyone speak to the use of cyproheptadine for either migraine treatment or prophylaxis in children?
Cyproheptadine, I would say, is commonly used as a migraine preventive agent in children and adolescents. The actual evidence for effectiveness is really limited. There's 2 non-placebo controlled trials, I believe, from the early 90s. So we use it because it seems to help some patients, but it has no better evidence certainly than CBT.
So, okay, thank you.
And has actually sometimes very bothersome side effects.
I have a question or a comment or just to bring something up. I kind of slant towards CBT being a very reasonable kind of thing to include. It kind of can help separate the suffering part, and that decrease in stress and all those different things can also prevent migraine onset and triggers and all this, right? And also I'm thinking about the biopsychosocial model, and then the argument that it is covered for the mental health conditions. And so that could be an avenue. So in a sense, there may be a feeling that, oh, well, the patient can get it if you use a code that marks it there. However, I'm wondering, with what you said about how CBT is for the headache, it's for that diagnosis.
Yes.
And I'm wondering if there's any, I mean, I don't know. So I kind of, maybe someone doesn't want to be diagnosed with a mental health condition or whatever it happens to be. Is there any harm in going the route of, using what is it called? Adjustment disorder? So is there any harm in using adjustment disorder and then writing in the referral, this is for migraine headaches?
Maybe you tell me on that, I'm not sure.
Well, I'm just saying.
I think that is often something that happens in clinical practice, because we can say that patients are struggling with coping with their headache disorder, for example, and they may meet criteria for adjustment disorder, but ultimately adjustment disorder and all of the psychiatric diagnoses have their own set of diagnostic criteria that some patients truly don't meet criteria for a diagnosis of those conditions, but still have a significant functional impact on their migraine headache and would still benefit from CBT for migraine.
Sorry to interrupt. This is Daphne. I wanted to let everyone know that Linnea has returned, so let the voting commence whenever you want.
Nice. Oh man, I just like went off of my train of thought a little bit.
I just
There's
have
another question.
Yeah, I just looked up, there's a study, a retrospective analysis from 2024. Now it's from Japan. So would that necessarily correlate with what we see here? But it does talk about ciprofloxacin treatment in children and adolescents with migraine.
I hadn't seen that study, but again, it's a retrospective study and not placebo controlled, so it's hard to know how to interpret it.
So I'm gonna jump in for a second. So some of the conversation this morning was, so to kind of frame the group, was where the gaps are. And so just to level set or make sure, and people can correct me if my understanding is incorrect, is that right now, if someone has another comorbidity, so anxiety, depression, we pull the list, adjustment disorder is, they have migraine, they are able to access CBT. So the place of the conversation is really for those patients who just have migraine headaches and would want to access CBT. And that is where at least some of the evidence that was provided this morning did not show a consistent benefit. So I guess I have two questions for the group, or maybe to keep things moving. My first question would be, is that it seems like you're talking primarily about like adolescents, pediatric patients. So maybe Ariel or Jason could talk about how EPSDT falls in. Does that cover that gap?
EPSDT.
What is EPSDT?
So this is the early prevention, screening, diagnosis, and treatment program, which means for OHP members under the age of 21, so before their 21st birthday, claims are not denied without an individual review based on medical necessity. Now that review can include HERC criteria, which would be if HERC says no, that could be used to support a denial. If there are other guidelines, the medical director could make a different judgment, decide to approve it in some case, but they would also be able to deny it. If HERC approves it, they should be covered.
Okay. So this discussion raises some questions in my mind. I don't expect that they'll be answered right now, but it also makes me wonder that in the identification of headaches and the treatment, and just particularly in terms of studies, is there any attempt to control various psychosocial stressors or SDOH factors, or quite frankly, we're seeing a lot more bullying, especially in social media, that can happen in schools. Is there any attempt to control any of those factors? Does that make a difference? I don't expect an answer about that today.
I would say there is often an attempt to control for those variables in migraine preventive treatment trials, particularly in children and adolescents. And there also is quite a lot of attention in research looking at rates of anxiety and depression and mood disorders in children with migraine who seem to be at higher risk of those comorbid psychiatric conditions. With respect to the role of those factors in these trials looking at cognitive behavioral therapy, on my review, they didn't necessarily structure the studies to look at differences in groups, whether they had anxiety or psychiatric comorbidities or just migraine alone. I think some patients met criteria to be in the study if they just had a diagnosis of migraine, even independent of other psychiatric comorbidities. So again, supporting the fact that this is likely helpful for migraine, even in children who don't have other comorbidities.
And just anecdotally, I remember as a resident, I did a CT scan of somebody's brain because they were having some headaches, and it turned out that all the patient needed was eyeglasses. So.
Yeah.
Dr. Burkholz.
There we go. Just on this question, is the HERC staff recommendation not adding cognitive behavioral therapy to the migraine line? Is that how we read this?
Staff recommendation based on the U.S. Preventive Services Task Group, I'm sorry, the ARC report that came out last year.
Okay, and I do see lack of harm, possible benefit, and then is the question for the HERC here to add it, although the recommendation is not to add it? I'm sorry.
This is the VBS report. VBS recommends making no changes You can
Okay.
approve that, or you can make another change. You are the decision makers.
Yeah, so just to clarify, so this morning, the VBBS did pass to follow the HERC staff's recommendation, which would not provide coverage for CBT in patients who have migraine without those comorbid conditions. So options on the table right now would be to pass the HERC's recommendation or the VBS's recommendation this afternoon. It would be to come up with our own recommendation and modify in real time, and we could vote upon that today. Or conversely, we could direct staff if there's areas of places that we would like additional information to be provided. So I will say both the testimony this morning and this afternoon have been very focused on pediatric populations, and maybe we direct staff to go back and make sure that there is not evidence that was missed for pediatrics, so we could provide some narrow questions to move this forward. Before I guess I go open up that door, I do want to comment to Ariel or Jason to see if there's a reason that we would need to be acting more fast on this topic, or whether we could do a little bit of a narrow dive similar to the previous topic as well.
There is no urgency here. You can, and, you know, whatever it takes to get you guys to feel that you are comfortable with the decision that you're making.
We also had submitted a written statement that actually summarizes a lot of the data, so that might be a helpful place to start if more research is.
Hey, I have a question also on the cognitive behavioral therapy. How long do these treatments last? Is this for a month and they're better, or is this a ongoing chronic disease type management?
So when we're doing a targeted course of CBT for migraine in our clinic, based on the amitriptyline plus CBT study that was published, we typically do 8 weekly sessions followed by monthly check-ins for up to 6 months or so. The 8 weekly sessions is really the bulk of the CBT treatment.
Okay, and you're using amitriptyline as well?
We're often using CBT in conjunction with other medical preventive treatments, but many patients are doing CBT plus even supplements, which also have some evidence for migraine prevention in this age group, or prescription medications.
I have a question for Ariel, and Dr. Green, well, kind of. Ariel, has that study that you mentioned, at first thing that you were quoting, Dr. Green, Ariel, is that included in our review, the materials that were reviewed for the staff recommendation?
I'm sorry, were which included?
Yeah, I'm like having a hard time formulating my question.
There's a couple of studies like the amitriptyline plus cognitive.
Yeah, the amitriptyline.
And then there's also a systematic review and meta-analysis from 2017.
Yeah, so I relied mainly on the ARC report, but I would be happy to look at any literature that our expert wants to provide, or any other areas that you would like me to look into.
Yeah, we have a full reference list in our written testimony as well.
Yeah, so I'd be happy to have her look at that or stuff.
Leslie, you've had your hand up for a while, so I want to make sure we get to your comment as well.
Thanks. I had a question for our expert. I was just wondering if when you're treating these youth and adolescents, if they're coming to you specifically because of the migraines, or if they're coming to you for like anxiety or depression related to the migraines' impact on their life. And it seems to me like the way I'm kind of thinking about this is it looks like for patients that have depression, anxiety, or other mental health diagnoses, they already have access to CBT, but I'm wondering if we need to set like a guideline note or something that connect the two, meaning migraines and co-occurring depression, anxiety, or other things, so that it does seem like if a clinician is looking for things that might help this population, I wouldn't want them to overlook CBT, because I think that the risk of depression and anxiety are, they kind of go hand in hand with intensive migraines as well.
Yes, so the patients that I'm seeing in my practice, which again, I'm a pediatric neurologist and headache specialist, and really I see probably 95% headache in my clinical practice. All patients are referred to me for the migraine problem. Many of them also have comorbid anxiety and depression, and the vast majority of those, I would say, are already getting psychological support for the anxiety and depression. So really what I'm advocating for is that CBT be covered specifically for the migraine problem, because in studies it seems to be effective in treating migraine, even independent of the impact on depression and anxiety. And migraine alone, even in the absence of anxiety and depression, has a significant functional impact on children and adolescents and their ability to attend school and participate in activities. And so I think that even children who don't meet full clinical diagnostic criteria for psychiatric comorbidity should have access to a type of therapy that can help them with resilience and coping with a really difficult pain problem.
So I'm gonna jump in. Is there any last burning questions? Because I think we are getting a little bit behind in the agenda. I wanna make sure we get through everything. Dr. Burkholz, Dr. Lyon, are there these urgent items, or can we?
Oh, my only question would be, would you feel comfortable limiting it to the study, the 14 visits for cognitive behavioral therapy, if it was approved by the HERC?
Yes. Yes, she said yes.
No further questions.
Okay, so I've been seeing Ariel, I think, taking lots of notes. What I'm going to do, so it seems like at least at minimum, what I'm hearing is there's not a lot of consensus from the group today. It probably seems worth tabling it. We'll make sure that we get the references that were provided as part of that public testimony. We'll go back and forth, make sure that in particular, the pediatric population is considered within this decision specifically. Is there anything else, I guess, quick items from the group that want to make sure that it's included as staff goes back and re-reviews this area?
Very quick question, and that is when the headache is treated, and if it is treated medically, does that help to alleviate anxiety and depression? In other words, is some of the anxiety and depression that may be related to headaches due to the headache itself? It's just a question that raised, and I think we need lots more discussion on this. So, and I'll be happy to wait for additional information.
Yes, I think that it is bidirectional. I think that.
Thank you.
Yeah.
Great. Dr. Burkholz, did you have a question, or is that just a hand? Just want to make sure.
No, I'm sorry. That's a hand doesn't automatically go down after you speak. I'm done.
Okay, so we will go ahead. Thank you so much for coming. So we will go ahead and move that item out for tabling and bring back at a further date. Ariel, do you want to try to finish the BBBS? I know we are behind.
Yes, of course. We had gotten through cervical spine manipulation, so we are up to
fissures.
Chronic anal fissures.
Page 126.
Was approved essentially with no changes from what you saw in your meeting materials, other than a friendly amendment that just changed. The wording in the 2025 guideline didn't match the wording in the 2027 guideline, so the wording from the 2025 guideline was carried through. Other than that, it was approved as you saw in your meeting materials. Any questions there, concerns? And then we talked about the benefit updates project as it relates to ENT. We talked about PE or tympanostomy tubes.
Page 137.
Tubes that go in the ear for effusions or fluid in the ear. The VBS members changed the proposed guideline to include all children up to the age of 21 to correspond with EPSDT, and modified some wording and kept some wording in there to clarify that these tubes are not included for adults because of lack of issues with language acquisition. So you can see some of the wording, the crossouts and the purple wording that sort of was added there. Otherwise, it was as you saw in your meeting materials. So it was approved as you saw. You will see this again because members felt that the revised guideline or the proposed new guideline was a dramatic improvement on the current one, and they want to see that guideline take effect 10/1/25. The staff are going to need to do a little bit of examining to see if there's anything else that needs to be changed if we make it effective earlier than 2027. And specifically what they were asking for 2025 was not adding coverage for chronic otitis media, but just changing the guideline. And it would still refer to both the covered recurrent acute otitis as well as the non-covered chronic acute, but it would have the criteria would be more clearly laid out for when things are covered. So you'll see that again, and hopefully we'll get it right. We talked about septoplasty and rhinoplasty, which the septum is the piece of tissue that's in the middle of the nose, and the rhinoplasty is repair of the nose.
Ariel,
Page 140.
excuse me. We had testimony on the PE tubes.
Oh, yes, we did. Are they here?
They are here.
Okay. Chair, are you okay with, we have a person testifying about a specific type of tube system who wanted to speak. Is this a good time?
Sure.
Okay. And they were here for my disclaimer, so we'll start with, one moment, please. Whomever wants to go first, could you please state your name for the record, your affiliations, and any potential financial conflicts of interest? Thank you.
Hello, I'm Megan Gelger. I'm the clinical strategy lead, and I'm here with my colleague Marissa Perales. She's the director of reimbursement, and we represent Smith & Nephew Ear, Nose, and Throat. And would it be okay if I share my screen?
No, we require slides to be sent 24 hours in advance. So please just give your testimony.
Okay. So thank you so much for the opportunity today. Our ask is for the Oregon Medicaid program to expand access for tympanostomy procedures performed in the office setting with the Tula system, billed with CPT code 0583T. Each year, approximately 700,000 tympanostomies are performed on children in an operating room, making it the most common childhood surgery performed with general anesthesia. The Tula system, which received FDA approval as a combination product and was designated as a breakthrough device in 2019, enables tympanostomy tube placement in an ENT clinic without the use of general anesthesia, changing the site of service from the OR to the office. As a combination product, the Tula system includes the local anesthetic drug and all device components required to complete the procedure and makes it distinct from other automated tube placement devices that have been introduced. During the Tula procedure, the child's eardrums are first numbed using specially designed earplugs and an iontophoretic drug solution. Then the automated tube delivery device is used to quickly and safely create the laryngotomy and insert the ear tube. 5 publications support the safety, effectiveness, and tolerability of the Tula system. And to summarize the clinical evidence, the Tula system showed positive outcomes with rates similar to those reported in the literature for conventional tympanostomy tubes placed in the OR, and there were 0 serious device, drug, or procedure-related adverse events. And now I'll hand off to Marissa.
Can we restart the timer, please, for Marissa? Thank you.
Yes. Apologies. Go ahead.
And again, Marissa, could you state your name, any potential conflicts of interest, and your affiliation? Thank you.
Marissa, you're now allowed to talk.
Sorry. Thank you. My name is Marissa Perales. I'm the Market Access Director here at Smith & Nephew. I'm not a provider, but I do work for the manufacturer. And so today, I just want to say, thank you for allowing us to present to Oregon Medicaid to discuss the Tula procedure. We're here to talk about the health economic benefits of the Tula procedure. So as my colleague stated, pediatric tympanostomies are commonly performed in the OR setting where there are multiple costs associated with it, whether it's the facility, the provider, and the anesthesiologist. The Tula procedure allows for ear tubes to be placed in the physician's office without the need of the facility or the general anesthesia, which can reduce the cost to the total procedure, as well as to the healthcare system and to patients. Additionally, the opportunity to alleviate resource time, both for facilities as well as for patients. The procedure in the OR on average is about 3.5 to 4 hours. The Tula procedure in our pivotal study was 33 minutes from start to finish. And so this is very similar to having an office visit. In addition, for many patients and families, ear tube procedures means that they are going to lose a loss of work, as well as the kids are missing a day of school or daycare, in addition to having on average about 24 hours of recovery time period. With the Tula procedure, in our clinical study, we saw patients resume normal activity about 76% of the time, and anecdotally in commercialization, we've seen that a lot higher. It also can alleviate any unnecessary stress for patients, as well as parents, considering the transportation cost associated with it for some families, child fasting, and the effects of general anesthesia exposure. It can also allow for having just a same-day visit, which can mean that in some cases, if given through the commercial or the existing coverage, they can get treated the same day. For some healthcare systems, there are longer wait times, so this is something that can help and benefit patients from getting immediate access. In addition to that, what we've seen in Oregon and in other states, commercial plans have started to expand access, seeing the benefits of not only just lowering the cost, but allowing the access to the patient population, and in some cases, alleviating the exposure to general anesthesia. And then in terms of Medicaid programs, we've seen South Dakota, Colorado, and New Jersey add Tula as a covered benefit. And then just recently, Utah has added as a covered benefit. In Oregon, we've also continued to see that increasing physician interest. And then most recently, there's some providers at OHSU, St. Providence, and other local hospital systems and children's systems that are looking at this to see if this is something that can be offered. And so they're really looking for Medicaid to allow coverage so they can offer it to their patient population. Thank you.
Thank you both. We are running a bit behind schedule, so what I am going to do is I think that HERC staff will outreach to both of you after the end of the meeting to gather additional information, and we can bring it back to a later date.
I have a quick question. Doesn't have to be answered now. Was there any consideration regarding ear tube placement harm that went into the decision about coverage? And if there was there consideration of the method of ear tube placement? Thanks.
Is that addressed to me?
Whoever can gather some information about that would be great.
What you're seeing in front of you is a BUP change. So it's our current coverage. For chronic otitis media, it is below the funding line, but we don't have a funding line anymore in the BUP world, so it's kind of moving up. When the initial, so up until the mid 2010s, when there was a economic downturn, chronic otitis media was covered under OHP.
Ariel, I think he's asking about the delivery system for the ear tubes.
Yeah.
What was represented in the evidence base? Is that right?
Well, I'm asking that question and an additional question, because what I'm reading is that ear tube placement in older children and adults, actually there are some harms associated with that. I'm wondering if that was part of the calculus in the decision. And then if there was that consideration, did that consideration have anything to do with the type or method of ear tube placement?
I am reflecting, what you see on the screen is reflecting basically our current mixed coverage, since we cover some and don't cover some. I'm assuming they took into account risks when they wrote the initial guidelines that were, we did allow coverage up to the 2010s. In terms of location, whether it's outpatient or inpatient, in preparation for this testimony, I did look up we actually do cover, it's really a coding issue. We cover outpatient tube placements with other codes. This particular system has a specific code that that's kind of the issue. The generic code for outpatient tube placement is currently covered.
Ariel, that was my exact same thought, is what's the CPT code? And I see it's a T code. And my understanding is OHP does not cover the T codes, correct?
We do not cover T codes unless we are directed to and there's no other code that's available. My limited correspondence with these testimony folks is that they are required to use this code. They cannot use the generic CPT code, I believe because it doesn't include one portion of their procedure. But I can look into that. We can cover T codes when there's no other way to cover a service.
I see. Yeah, and that's really what it comes down to. It comes down to the coding and what's it submitted under.
I'm also just thinking about, language acquisition is one thing, but the ability to communicate, hearing, also pretty important, even for adults.
So what do folks want to do today? Do we want to table this entire conversation while we gather more information about the billing and connection with about the TULA system or the billing? Or Ariel, do you have a specific recommendation?
Yeah, so I think with what the testimony was today was about a specific service that we cover a more generic version of. I think that's a completely separate issue that I can work with the testimony folks and bring back to you about whether any recommendations to cover this system. I think what you see in front of you is a BUP issue that you can approve today if that is your desire, knowing that the specific issue brought up by our testimony can be addressed in August or later in the year.
Yeah, I don't think that the regarding the testimony for this new type of procedure, I don't think that is urgent, that has to be addressed today. I think that can wait. I'm comfortable with that.
Any other questions about what we have on the screen?
And Mark, do you have your hand raised, or is that from your previous comment?
Sorry about that.
I do have another question. So I want to get back to being able to hear. Are conditions that for which ear tubes could be placed for difficulty hearing, is that otherwise covered elsewhere in some way? In other words, a different treatment for hearing loss or the difficulty hearing?
So Dr. Light, I think maybe, we do need to get through the VBBS report as presented this morning.
Yeah, I'm comfortable with waiting. Yeah, I'm
we can hunt that question and table it, and we can focus on, or just make sure that we get through the report, because we do have to get through this report.
That's fine.
Thank you.
Okay, so where are we? We are on the PE tubes. So the only change from what was in your materials was what you saw in on the screen in front of you. And then what was next? I am losing my place. For septoplasty and rhinoplasty, there were a few
Page 160.
There were a few modifications to the staff proposal. VBS members felt that if a septum is causing nasal obstruction, that's actually not a medical issue, it's more of an inconvenience, and they struck that portion of the guideline. And then for the rhinoplasty portion, I apologize, but I inadvertently left off a piece of our current rhinoplasty guideline that deals with nasal fractures. That was added back in as a friendly amendment with only technical changes. I think that is the list of changes that we did.
Hey, Ariel, on the obstruction, can you go back? we're seeing a lot of, 75% obstruction on CT scan, partial obstruction, moderate obstruction, severe obstruction. I assume that is 100% obstruction. Is that correct?
This didn't clarify. So we now only have surgery due to deviated septum when it's causing recurrent epistaxis or recurrent sinusitis.
Okay.
We took
Okay,
out
okay.
the
Okay.
obstruction.
Okay, you took it out. I'm sorry. Yeah.
We did, that was one change. And then for the rhinoplasty, we added in some wording that had been left off. And then for the sinus surgery guideline, there were indications for sinus surgery. And it previously had been 2 or more courses of antibiotics and a trial of steroids. It was thought we also should add adequate treatment of allergic rhinitis if present, because there's more treatments than just the nasal steroids that could help that. So that was what you see now is that B under the highlighted, the adequate treatment for allergic rhinitis, that was added.
Mark, were you asking about nasal or sinus obstruction? Oh, you're on mute.
It's this Zoom. It's killing me. I was talking about nasal and the current, it's actually the current guidelines with the obstruction, which is very not clear. Taking it out is much better.
Yeah, it's below the line now. Nasal obstruction. The septoplasty.
And Mark, if you like taking it out, we could always bring that back as a proposal for a 2025 change.
26.
Ariel, let me think about this for a moment.
No worries. You can get in touch with me with email.
Thanks.
Well, Mark is thinking about that. I have a question. I'm seeing the coverage guideline note, coverage guideline 216. It says rhinoplasty is medically necessary for gender affirming treatment. Is that by legislative imperative?
Yes.
So that's not anything that we need to discuss or talk about. Is that correct?
Correct.
Okay, thank you.
All right, so that is our septoplasty or rhinoplasty nasal polyps. We then talked about salivary gland issues. The change here was that sialolithiasis, which is stones in the salivary glands, and mucoceles, which are just sort of like a little pearly growths, were only available for medical management rather than surgical. Otherwise, it was approved as was in your meeting materials. And lastly, we talked about vocal cord issues, and the recommendations that were in your meeting materials were approved as presented.
I thought we made one change.
Oh, we did too. Oh, I'm sorry. I had a note that we made a change. I couldn't find it. Paralysis of the vocal cords unspecified was proposed for surgical code grouping, and it was moved to evaluation of medical management because unilateral and bilateral paralysis are both in that surgical code group. So unspecified was thought to be not needed. Apologize for that. And then the final 3 ENT topics, which were tympanic membrane preparation, tonsillectomy, and then a miscellaneous group, were tabled until the August meeting. And then you will hear about our coverage guidance. Then there were some VBS changes in the recommendations for changes to the prioritized list, but you will vote on that separately. So that ends the VBS report.
Any questions? Okay. The 2 items that I have tabled are CBT and migraines, and then There was a second.
Cervicogenic.
headache.
And then the Tula and the questions Larry
And then
was
the
raising
Tula.
about.
And then 3 of the ENT topics.
Yeah.
And then the 3. So I'll put, do I have a motion otherwise to approve the VBBS report outside of those items? So moved from Lisa, second?
Second.
Second from Max, as well as I see Dr. Lyon raising his hands. Can we roll call the vote?
Yes. Mark Buckholtz,
Approved.
Max Kaiser,
Yes.
Lisa Kuzins,
Approved.
Linnea Lindsay,
Approved.
Larry Lyon.
Dr. Lyon, you're muted.
Sorry, approved.
Thank you.
Leslie Sutton,
Yes.
Adrian Irwin,
Approved.
7, and that motion passes. Thank you.
Okay, thank you. So we are a bit behind schedule, but we can get caught up. So the next item on the agenda is the EGBS report.
Just to kind of touch base with you all about, it is currently almost 3:20 when we were supposed to discuss our coverage guidance. We could table the EBGS report until August or circle back to it after the coverage guidance, if that would be preferable. It's
Mostly efficient.
It might actually be preferable for staff because we could then put the final EBGS recommendations out for public comment, although they're essentially very similar to what was already out.
We should do
Whatever.
what's easiest for staff.
I agree.
Jason, do you have a preference?
No, that sounds great. Let's do the coverage guidance first and see what else we get to.
Page 199.
Okay, thank you.
All right, good afternoon, everyone. My name is Marcus Bachhuber. I'm with the Center for Evidence-Based Policy, and I'll be presenting an abbreviated version of this coverage guidance. Apologies to those in BBBS earlier this morning who heard it, but it'll be an abbreviated presentation. So we have no conflicts of interest to disclose, and the full CG is in your meeting materials. The Center for Evidence-Based Policy, we're contracted by OHA to carry out systematic evidence reviews. Basically, we execute the scope that is given to us by HERC. And if we have questions, we ask for clarifications. We're not involved in any of the coverage decision recommendations or the staff recommendations or anything like that. We just provide the systematic review. Here's our team. So it's me, Dr. Val King, our research director, Shauna Durbin, who's the research lead for this project, and Courtney, Jen, and Jana, who are the research associates. And for this topic, we were very lucky to be able to work with 2 experts, Derek Lamb and Lou Libby, who are both physicians, one's ENT, one's sleep medicine. And I believe Dr. Libby's on the call with us, who will be able to answer some questions. We greatly benefited from their input. This is the second and final part of the evidence reviews on obstructive sleep apnea. The first one on hypoglossal nerve stimulation was discussed at EBGS in September, and the decision at that time was to table it for 1 year.
Marcus, this is Daphne. Dr. Lamb is also here, and I'll promote Dr. Lamb.
Thank you, Daphne. So OSA is a disorder where breathing is interrupted during sleep, causing disrupted sleep, a low blood oxygen level, or both. It's associated with lower quality of life and cardiovascular disease. OSA is diagnosed through testing in a sleep lab or at home to identify respiratory events, which are defined as apnea, which is a complete cessation of airflow, hypopnea, which is a reduction in airflow of 30% or more for 10 seconds or longer, with a reduction in oxygen saturation by 4% or more. That 4% is the Medicare and OHP definition of a hypopnea. Other payers can use different ones, and there's different ones out there, but that 4% is what is used by OHP. The count of both of those together is called the apnea-hypopnea index, or AHI, and you can use that to classify OSA as mild, moderate, or severe using the thresholds you see there. The oxygen desaturation index, their ODI, is the count of desaturations, and that's another measure that's used. CPAP is the first-line treatment for OSA. As you can see there, it's an external device that creates a constant flow of air to support the tissue of the upper airway to remain open. So the purpose of surgery for OSA is to address any issues or abnormalities in the structure, function, or both of the upper airway. It can also potentially improve the efficacy and tolerability of CPAP therapy, and surgical techniques in this area, as with many areas, are constantly evolving. Because a person's airway anatomy can be different while they're awake versus when they're asleep, there's a test that can be used to identify the structures that are causing issues during sleep, and that's called drug-induced sleep endoscopy. That's where a camera is inserted into the nasal passages or in the throat and the upper airway under a light dose of sedation to mimic sleep. And surgeons can use DICE to guide their approach to surgery and identifying surgical candidates. So for the scope statement, HERC included adults with moderate to severe OSA, focusing on all surgical interventions for OSA, including upper pharyngeal procedures, lower pharyngeal and laryngeal procedures, and jaw procedures like maxillomandibular advancement or expansion. Excluded from this review is prescription drugs because those are managed by pharmacy and therapeutics, hypoglossal nerve stimulation devices, that's a separate coverage guidance, nasal surgeries alone, airway surgery is no longer used in practice, and tracheotomy or tracheostomy, which is typically an intervention of last resort except for specific circumstances. The eligible comparators were non-surgical OSA interventions such as PAP or oral appliances, waitlist or no treatment, and we excluded comparisons between different types of surgeries. Those are included in the separate comparative effectiveness question, so we do have some of that data you'll hear about later. HERC selected 2 critical outcomes, quality of life and procedure-related serious adverse events, and 3 important outcomes, change in OSA severity, daytime sleepiness, and major adverse cardiac events. For effectiveness questions, we included randomized controlled trials of any size and comparative prospective cohort studies of greater than 100 participants. For harms, we included those studies as well as systematic reviews, single-arm prospective non-randomized studies of over 100 participants, and registry studies. The key questions were, what is the effectiveness of surgery versus non-surgical treatments? What are the harms? And how does the effectiveness and harms of these interventions vary by patient characteristics and intervention characteristics? The 3 contextual questions were, first, what's the evidence of surgery on outcomes using a more broad approach to evidence? And what is the comparative effectiveness of surgery for OSA from RCTs? Finally, what is the cost effectiveness of surgery for OSA? So we worked with the information specialist to develop a comprehensive search strategy of multiple evidence databases. And for policy items, we searched the sources you see there. We did expedited dual review of search results and risk of bias assessments, and all methodological quality assessments for guidelines were by dual independent review. We assessed the strength of evidence using the grade system from very low to high. Very low being the true effect is likely to be substantially different from the estimate of effect, and high being we're very confident that the true effect lies close to that of the estimate of the effect. And our findings. So we identified 2,390 records after deduplication. And of those, we found 13 studies with 16 publications were eligible, along with 8 evidence-based recommendations. These were typically guidelines or position statements. The eligible studies described 3 surgeries. First is uvulopalatal pharyngoplasty, or UPPP. And that's a surgery focused on removing or repositioning excess tissue from the throat to widen the airway. You can see in that diagram there, on the left side, the throat is more crowded, and on the right, the throat, there's more space, and the airways has a wider area. UPPP is interesting because it's a surgery that has developed over the years, and it's kind of a family of different procedures that are all related. It's not one specific singular procedure. Barbed repositioning pharyngoplasty is considered generally in the family of UPPP, and it's the use of special sutures to reposition the pharyngeal palate muscle to widen the airway. And the third surgery is maxillomandibular advancement, which is a jaw surgery involving repositioning of the bones of the upper and lower jaw to widen the airway at multiple points. And it also typically requires corrective dental treatment afterwards. So for UPPP with tonsillectomy, we identified studies with about 13,000 participants. For MMA, we identified studies with about 631 participants. And for barbed repositioning pharyngoplasty, we found studies totaling 1,581 participants. There was one study we found which involved multi-level, multi-stage surgery. So this was multiple different surgeries at multiple different points in time. And all of those folks initially got the UPPP with or without tonsillectomy, so we included this study in with the UPPP data, just to make it a little easier to compare apples to apples. So here's our summary of the outcomes. So for quality of life, that's the critical outcome. We found low certainty of benefit. For OSA severity, which is an important outcome, we found low certainty of benefit. For daytime sleepiness, we found low certainty of benefit. And for major adverse cardiac events, we found no eligible studies that could comment on that outcome. It's worth noting that for quality of life, we didn't find any studies of maxillomandibular advancement or MMA. And for OSA severity and daytime sleepiness, there was a study. However, there was no difference found between MMA and the comparator. For harms, we found moderate certainty that we have the full understanding of the scope and magnitude of the harms. For UPPP with tonsillectomy, total serious adverse events were reported in 0 to 7.1% of participants, with repeat surgery in 2.6% of participants and death in 0 to 0.2%. But you couldn't necessarily attribute the surgery, the death to the surgery because of the research design. For MMA, total serious adverse events were reported in 0 to 18% of participants, and repeat surgery in 1.7% of participants, and no deaths. So for contextual question 1, we identified 3 systematic reviews that were relevant to this. One on mortality, which found inconsistent results, with the most recent study in 2004 finding UPPP compared to CPAP to be associated with lower mortality. For stroke or transient ischemic attack, UPPP versus no intervention was associated with a lower risk of that outcome. And in cardiac arrhythmia, there was no significant difference with UPPP. For comparative effectiveness, so this is comparing different surgeries, we found 5 relevant studies. I just want to direct your attention to the last one on the row, the last row in the table, excuse me, and that was of tonsillectomy alone, which is just removing the tonsils, versus modified UPPP, which is removing or repositioning tissue of the throat in addition to removing the tonsils. So the tonsils is tonsillectomy is a more limited procedure. And in this study of the patients that were selected, the outcomes were pretty similar, suggesting that tonsillectomy alone has similar outcomes to more intensive surgery in patients who are selected by the criteria used in that study. For cost effectiveness, we prepared that in compliance with Senate Bill 1508, which prohibits HERC from considering QALYs or any similar quality of life in general measure. And at the time of our search, we didn't find any US-based cost effectiveness studies that used other measures than those. There were no ongoing studies at the time of our search. And so now we'll move on to guidelines and recommendations. So here are the guidelines. This table will be, you'll see this table in the next couple of slides. Each column is a different procedure organized by the area of the anatomy. So the first group is the upper pharynx or upper throat. Then there's an either, which can be upper or lower. Then there's a lower pharynx or lower throat, a larynx, which is around the voice box, and a jaw, which is the surgery to the jaw bones. So we identified 6 guidelines, and guidelines tended to be focused on a specific type of procedure versus broadly applicable to all the procedures that we're looking at. So in the VA Department of Defense guideline, which we rated as good methodological quality, it was only looking at MMA and it recommended MMA. For the German Sleep Society, which was a fair methodological quality, recommended UPPP and MMA. The European Respiratory Society, which was fair, was only focused on MMA and recommended it. The Japanese Respiratory Society, which was also fair, did not recommend other procedures, but did recommend MMA. The American Academy of Sleep Medicine and the NICE guidelines were both rated as good, and they had language around discussing referral to a sleep surgeon, but didn't really get into the details of specific procedures that were recommended. So now for payer policies. So here's the same table in a similar format where each row is a payer. And I'll start with Medicare, which is the second row. And it appears that a lot of coverage flows from that Medicare LCD cited there. So Medicare covers UPPP, tonsillectomy alone, tongue reduction, hiatal suspension, genioglossus advancement, and MMA. And that's exactly mirrored by Washington Medicaid, although their coverage last date of review was in 2012. And Aetna, Cigna, MODA, and Regents have similar coverage with a little bit of discrepancies in the area of tonsillectomy alone and in the requirements around MMA, but otherwise mostly the same. Okay, and then I will kick it over to you, Ariel, for the discussion.
It looks like Larry has a question.
Oh.
Provide any information relating to the contextual questions and specifically relating to motor vehicle crashes?
The studies that we found that were eligible for that question for CQ1 did not have information about motor vehicle accidents.
Okay, thanks.
All right, are we ready for discussion? So the staff recommendations, this is basically an overview. You see all the details in your packet. Based on the evidence review, we're proposing coverage of UPPP and tonsillectomy alone for people who can't have UPPP, for patients with moderate to severe sleep apnea who you'll see the criteria in a minute. And then we need to discuss whether or not we want to cover diagnostic sleep endoscopy or drug-induced sleep endoscopy. We currently cover that for children, but whether we need to expand that coverage to adults. And there's no recommendation for any expansion in coverage for the jaw procedures like MMA, for obstructive sleep apnea, although we will continue to cover it for craniofacial anomalies. We also cover CPAP and oral appliances. I know there were questions this morning about coverage of oral appliances, and HERC staff have been working with the DME staff about the mandibular advancement devices. The intent is to cover, and we'll try to make sure that we are actually doing that. Next slide, please. So the first recommendation for UPPP, which is very similar to our tonsillectomy alone, is that you need to have an AHI-4 of 15 or greater, that's moderate to severe sleep apnea, and have inadequate response to CPAP or can't tolerate CPAP, and you have to have evidence of anatomy that would be conducive to the UPPP. Next slide, please. And this is based on low confidence that we have in that this improves quality of life and daytime sleepiness and OSA severity, and that outweighs the adverse events. Next slide, please. Coverage recommendation 2 is the same thing, but for tonsillectomy, you'll see the first two inclusion criteria are the same, but it would need a tonsil size of 3 or 4 on the Brodsky scale, which is standard, and not be a candidate for concurrent UPPP. Of note, tonsillectomy is part, I'm sure, you glean that from the previous presentation, it is actually part of generally of a UPPP. Leslie, I see your hand up.
Yeah, I just had a question about inadequate response to CPAP. In the developmental disability world, there's lots of people that use CPAP and actually need to have staff support sometimes throughout the night to make sure the mask stays in place. Would that be enough to say it's an inadequate response to CPAP and therefore they would be able to have this covered? Or how would you handle that? How would this handle that when someone needs to have actual, like another human in the room or periodically checking or awake in the home to ensure this CPAP can stay on?
You are foreshadowing the VBS discussion. They would like some more information So this is the coverage guidance, which is a general recommendation for insurance. And we'll talk in a little bit more detail about what VBS discussed about changing the prioritized list to go with this. They did want a better definition of inadequate response. We did not talk about folks who need assistance with use, but that's a really good call out. I'm glad you brought that up. And I may be getting in touch with you in a little bit to just kind of nail that down a little bit further. But yes, there is a lot of questions swirling around about what is inadequate response, or what, if in your case, if a person really needed an assistant or a support person to use it, that's not practical, would that constitute, that this isn't an appropriate therapy for them, perhaps. Next slide, please. So this is going back to just the tonsillectomy without UPPP. We felt that there was a clinically meaningful benefit that outweighed the risks for this. Next slide, please. And then we don't, this is the same thing, we don't recommend the maxillomandibular advancement surgery. Next slide, please. And this is because of insufficient evidence. Next slide. So overall balance of benefits and harms for UPPP and tonsillectomy, the benefits do appear to outweigh the harms, but not for the MMA or the procedures. Next slide, please. Resource allocation, we do realize this is an issue. There are only a few providers who do this complex upper airway surgery. It may not be available in certain parts of the state. To operationalize coverage of UPPP, we will need to get our heads around whether or not we want to cover the drug-induced sleep endoscopy, which adds additional cost and anesthesia risk. Our expert did talk about the fact that he recommends a DICE before any consideration for UPPP, and it's because he has found patients who wouldn't be candidates, and therefore they avoid an unnecessary surgery that has the risks. So there's pros and cons. Some patients would prefer that something that is a one-time treatment, like a surgery rather than CPAP, although many will require CPAP regardless of surgery, but they may be able to better tolerate it. And that, again, we need to make sure that there's access throughout our state for these procedures. Next slide, please.
Last one.
Last one?
Yep.
All right. So going back to what I had briefly mentioned with Leslie's comments, this is your coverage guidance. So you would vote to approve this as a general recommendation for all insurance. And then we can go into the recommendations that VBS talked about as it applies to OHP, which they did not actually vote to approve. So there's no vote on that portion. Your vote today is on the coverage guidance.
Is there any provision for exception?
So this is a coverage guidance. It's not our specific coverage. So this is just a global recommendation.
Okay, all right, thank you.
So this is, now we're moving forward to the portion, and again, this was tabled for further input. I want to discuss it with you all in case there are other questions, such as Larry's question about exceptions, Leslie's question about people with perhaps special needs with use of CPAP. If you want to go down a little bit, Liz. So the recommendation from staff was to modify the current surgery or certain treatments for obstructive sleep apnea guideline to go along with this. So all of the current codes are available on that line for all the procedures we're discussing because they are already available for children. So we don't need to do any code changes. What we would need to do is change our guideline. And just keep going down, Liz. It's a bit further. So the recommendation, what we currently say in our treatment of sleep apnea guideline is that surgery is not covered for adults, full stop, because of lack of evidence. So that would be struck. That's the next page, Liz. And so there is criteria, including a 12-week trial for CPAP. Above, you can see that. So we would strike out the no surgery for adults. We would put in surgical procedures would be covered. And then criteria for the UPPP would be what you saw in the coverage guidance blue box. You have to have moderate to severe sleep apnea as defined as an AHI 4 score of 15 or greater. An inadequate response to CPAP therapy or cannot tolerate CPAP. and then evidence of that physiologic obstruction. The main discussion that we had here at VBBS was that the members really wanted inadequate response to be better defined. There were suggestions about requiring a certain period of a trial, and perhaps a month trial with also a follow-up visit with a sleep specialist or a respiratory therapist who specializes in CPAP for better fitting in different masks. There was no wording that VBS approved. I was just instructed to follow up on this. And then based on Leslie's comment, I think we may need to put some wording in there. So adults or children are already covered, but for adults with special needs with use of CPAP, we may want to put, if CPAP is not feasible due to a medical issue or something, some wording. I can work with Leslie on that. So that I would love any feedback, any additional comments that you have on that coverage criteria. And then for tonsillectomy alone, the coverage is essentially the same. And the same question about what is inadequate response to CPAP, we'd have to address that. And then
go ahead.
All other surgeries are only for children, and that would be like the MMA and other types of craniofacial kind of reconstructive surgeries. I see Larry's hand and then Mark's hand.
Quick question. So when I look at this and I see all the criteria to be able to qualify for this procedure, and I've seen this in other types of requirements for procedures, does the clinician actually do this documentation, and is this documentation actually reviewed in order to be able to get payment for the procedure?
This was reviewed extensively by our experts, including Dr. Lamb, who does this surgery, and they had no objections. So I would assume this is probably required by other insurers or something similar.
No, right. I understand that the experts recommend this and are comfortable with this. My question is do clinicians actually document all of these things?
Yeah.
Yes.
Yes.
Okay. All right. Okay. Thanks.
They provide the records. Do what you gotta do.
Mark?
There we go. Many monitors. The question is on the AHI. The moderate is 15, severe is 30. I was just noticing one study using the UPPP had a mean AHI of 62 plus or minus 35. Is there any harm in changing it instead of moderate and severe, just make it 30 AHI? What is I guess I'm looking at the data to support the 15 to 30 as opposed to just severe treatment with the surgical procedure.
I'm going to let Marcus address this in a second. My understanding, and Marcus will correct me if I'm wrong, was that the study entrance criteria was an AHI of 15 or greater, and it just so happened that it was more severe in the study population. But Marcus, can you address that?
Yeah, that's exactly right. I think we have, just looking at the slides here, and one of the supplementary slides, we have the baseline characteristics for the different, here, the baseline characteristics for the different studies that were included. You can see each column is a different characteristic and each row is a study. And within each study is divided into the intervention and the control groups. So there's a column, it's 1, 2, 3, 4, 5, the sixth column over, that's the mean AHI of the participants. So you can see on average they were fairly high, but there was a range that standard deviation is pretty wide. And so all of the studies, the inclusion criteria was moderate to severe. That's why we included it in our review. It just so happened that the people enrolled tended towards the more severe, but there was a range of people enrolled in the study.
I mean, would this data support a higher range? I mean, I know I see the standard deviation, but it seems like it would be closer to 30 for a mean, correct?
The inclusion criteria for the studies was moderate to severe. and there was a range of people enrolled, and that's pretty much all that we can say. I don't think I wouldn't be able to draw any conclusions about that. It's only these studies are only applicable to people with more severe OSA because they were open to people who were moderate to severe, and there was a range of people enrolled.
Right. It was open to moderate to severe, but the data is on severe. Is that correct?
That's not the way that I interpret it, because the mean is in the severe range, but there is a spread of people in the moderate and throughout the moderate to severe category.
Yeah, like the Somner study, since the range would go down to 15, it looks like. But I see Dr. Lamb has his hand raised, so maybe he can help clarify. Dr. Lamb, can you unmute? Perfect.
Or can you?
Yes, we can hear
you. We can't hear you.
Right.
Maybe you turn your video off. We might have better audio.
Hear me now? No?
Better.
Nothing?
Better, yeah.
Yeah,
You
better
can-
now.
Better now? Okay, great. Sorry. Yeah, I mean, I think what Marcus was saying was exactly right. Like, there were definitely people in the moderate range that were enrolled in those studies. It's not like they were all severe. It's just that you had some people that were very severe and dragged the mean up, right? But more importantly, I think that the benefit clearly applies to people with just moderate sleep apnea as well. It's like a lot of the sequelae for sleep apnea really start with moderate severity of disease. And so the question shouldn't be like, are the severe patients going to the only ones that are going to benefit? Like, should we only offer this to patients that are severe because that's what's in the studies? It should be like, who has the most burden? Like, who does it make sense to treat because of their burden of disease? And clearly, if they have at least moderate sleep apnea, then they deserve to have their sleep apnea treated. And if they're not tolerating CPAP, then what is their option? Right? Like, I think that's kind of how we look at it. Like, if they can't have surgery, then they just remain untreated and then potentially have all the downstream sequelae of untreated sleep apnea. I don't know if that helps answer the question.
Did that answer your question, Mark?
Well, it does, but I guess my question is, how many moderates do you have to treat to prevent it from becoming severe?
This is Marcus. We don't have any information on that. We don't have any information on that in these studies.
Yeah, and Marcus, if I recall correctly, when you did the review of other policies, they also cover moderate. Is that correct?
That's correct.
So it would be consistent with private payer and Medicare.
I know, I was just questioning it, that if obviously the severe, but then there's a decreased benefit the more you cover, then you get less bang for the buck. That's where I was going with this.
Yeah, I think there's multiple potential ways to look at that, and obviously the experts can jump in if I'm misstate that people who are in the more moderate range may have abnormalities or functional changes that are more amenable to surgery, and they're more likely to have a remission potentially of their sleep apnea. Whereas people who are in the more severe range, they may not ever get the apnea under control by the definition of it, using the AHI cutoffs. But even some improvement is helpful to them. So, and the nature of their structural or functional differences that are causing their OSA are potentially different than those in the moderate range. So I think that it could potentially benefit both groups, and there's probably quite a bit of overlap in between the groups. But again, I would defer to our experts on that. That's my read of the research.
I mean, I think that's a reasonable interpretation, Marcus, for that. Like, in my mind, I don't see a great distinction between moderate and severe in terms of need for treatment. It's like you said, I think it's just harder to, get someone who's way into the severe range down all the way to like mild. That your goals for treatment may be less in terms of like, reaching some threshold that you might define as success, but they clearly still deserve to be treated, right? So.
Any other questions?
In general or about that topic?
I guess about the coverage guidance, because the coverage guidance is what we have an opportunity to vote on today. Ariel or Jason can correct me if I'm wrong, but we can vote on that piece of it. And then the broader discussion related to the operationalization that'll come back to BBBS, comments are open, but we can keep those separate. So maybe we'll start right now with any further clarifications you need on the coverage guidance before we vote on that topic. Hearing no comments, does Mark, okay. Does anyone want to make a motion to accept the coverage guidance?
I move to accept the coverage guidance.
Thank you, Lene. Max is seconding. Okay, so why don't we vote on that piece of the puzzle? Daphne, can you help me with that? Or Jessica?
Sure. I'm just getting back to my desk after a break, so give me 1 second. Mark Buckholt.
Approve.
Max Kaiser.
Yes.
Lisa Kuzis.
Yes.
Linnea Lindsay.
Yes.
Larry Lyon.
Yes.
Leslie Sutton.
Yes.
And last but not least, Adrian Irwin.
Yes.
That's 7 and motion passes.
Great. So now I think let's take any final comments. So Ariel, if it makes sense, do you want to, maybe we can open it up for any final comments or things to look at as we start crosswalking this into how to operationalize that and what will come back to BBBS. Does that work?
Yes, the two pieces that I'm already working on is working with other parts of OHA about coverage for the mandibular advancement devices that we have previously wanted to cover, just make sure that that is something that is working. And then the other piece is the failure, quote unquote, of CPAP. What does that mean? Coming up with better definitions, looking at folks with disabilities, how that might apply to them. So I have all of those noted down as things to look at. And then, Mark, if you're still really concerned about covering for moderate sleep apnea, we could always talk about whether we want to include a AHI of 15 or we want to go to 30, if that is what the group wants to do.
No, I'm comfortable with the current, the 15. As long, just wanted to validate the data. Of
course. Any other things for staff to work on, or?
We talked about the hierarchy of where that mandibular device fits in, where the drug therapy might fit in versus CPAP versus surgery. Does that ring a bell?
I had clarify when mandibular advancement device is recommended before surgery instead of surgery, and also, I forgot to mention this piece. Where is medication in the pathway? I have a note to talk to our PNT colleagues about the medications.
Are we talking about the DICE portion now, or is that next?
We can talk about DICE now, yeah.
Is it just I ask questions about it, or is there anything to
This is you ask questions.
Okay. Yeah, I guess the question was, what is the evidence supporting its use? And then how does that, I guess its use in choosing surgical procedures and outcomes, how often does it change it? How effective is it, et cetera? You know, like any other diagnostic intervention. Because I don't think we covered that, right?
I think that's a clinical, highly clinical question for the experts. Well, so there was no studies that compared a DICE guided surgical approach to a non-DICE guided. Like there's nothing like that.
Yeah, that'd be my.
Yeah,
because we're supposed to say what's the efficacy and utility of it, right?
Right,
We would have to see if that changes surgical outcomes.
Yeah, but it's a little bit difficult because, and correct me if I'm wrong, Dr. Lamb, that to be able to identify patients eligible for the procedure, you often need to do a DICE because their airway anatomy while they're awake can be different than while they're sleeping. So there's not really a situation where there could be a head-to-head type counterfactual design.
It was just kind of accepted as standard of practice for these surgeries, so nobody even checks doing it without.
Yeah, maybe in earlier surgeries predating the time that we were looking at, it was done without because that technology wasn't available. I don't know. Again, that'd be the question for the experts.
Okay.
But in the time of the surgeries the studies that we looked at, I believe many, if not most of them, use that to identify candidates.
It's just kind of a package.
There was
Yeah,
only one that used DICE.
That use DICE, okay.
And to be fair too, it's not just this particular procedure. Like the DICE is usually more general to evaluate anatomy and try to help give the patients guidance about their treatment options, which might actually include non-surgical options as well. So, there aren't any studies that directly compare, DICE and no DICE for, at least with respect to the outcomes of these particular procedures. You will get debate amongst otolaryngologists and so forth about how and when, like how often and when the DICE should be used to help in these sort of treatment decisions. But I think it's fair to say that there's no clear evidence, pointing one way or the other on that.
Did I answer your question, Max, or do you have follow-up questions?
No, those are an answer. I'm just trying to think of corollaries where we would, and how we've done decision-making in those, because essentially we're just going off of it.
I will say that I am in the process of carrying out 2 randomized trials specifically to try and answer that question, but only in kids and only in specific subpopulations of kids, like kids with Down syndrome and kids with small tonsils. So I'm trying to provide some evidence for that, but it would not directly address your question in adults today. So
yeah, I think Max, we're kind of left with expert input and general practice pattern at this point.
Yeah, and it sounds like that's, if anything, standard and up to the individual, and it would be atypical to not allow that. Okay.
Yeah.
I kind of thought we covered diagnostic stuff without really much questioning.
We usually do. In this case, we had done a review and not found sufficient evidence in the past, so we're revisiting it in light of potentially adding this coverage.
And I've only seen a link to, different interventions of, oh shoot, what nerve is it still? Phrenic nerve stimulator? Is that it?
Hypoglossal nerve
stimulator.
Yeah.
And just to be clear, let me just read the bios of our experts because I think it's relevant here. Dr. Derek Lamb is the Associate Professor of Otolaryngology at OHSU. He is also Surgical Director of the Dornbecker Aerodigestive Clinic, where he manages complex aerodigestive disorders in children. Additionally, he's Surgical Director of the Upper Airway Stimulation Program focused on nerve stimulation to address adult obstructive sleep apnea. He conducts NHLBI funded research focused on diagnosis and surgical management of pediatric obstructive sleep apnea, no conflicts of interest that meet the HERC disclosure threshold of 200. So he is, correct me if I'm wrong, Dr. Lam, you are seeing patients who are being referred to you. You're not seeing patients first line, you're being usually referred by another sleep medicine physician, is that correct?
Yeah, that's correct. And I've actually mostly, because I'm primarily a peds guy and that's where most of my interest is, although I have certainly treated adults with sleep apnea as well. I've actually tried to phase most of that part of my practice out, and I've sort of handed off to a junior person at our department, but obviously have experience with adults and a lot of what we do in the kids is borrowed from just stuff that's developed in adults. And so like, I have to be knowledgeable about that to bring that to the kids. So.
And then Dr. Libby is a retired sleep medicine specialist practicing from 1985 to 2021 within the Providence Health System in the Oregon Clinic. He's board certified in sleep medicine, pulmonary medicine, and critical care management. During his practice, he treated many patients with obstructive sleep apnea and has no conflicts to disclose. So a much broader patient population.
Jason, this is Daphne. I just wanted to point out that Dr. Lamb added in the chat that he is a full professor.
Oh, thank you. Congratulations.
Congratulations.
Yeah, that was as of like last year. That's okay.
testament to how long this process goes.
Okay, well, we are scheduled till 4:30 and we are going to try to tackle at least some of the HEBS report. So I am getting a note that maybe we should take a 5-minute break unless there's any further comments on this space. Then we can reconvene at 4:01 and see how far we can get in that report. Any final comments on this topic before her staff kind of goes back and brings us further recommendations? Okay, perfect. Thank you so much, and we will reconvene in about 5 minutes.
This one, you know. Second one, no. No.
Hi, how many members do we have online here?
This is Leslie.
Hey, Leslie.
As of
I'm
July
looking.
1, I'm professor.
Why?
I mean, it's still true.
I know. I have 18 days. And then it'll be official.
Congratulations.
Full Professor Irwin.
Full professor. It'll be effective July 1.
Yeah.
Your bio, for sure.
Huh?
That's true.
That is a huge accomplishment.
Yes, big academic class.
Your last
Now
promotion.
you can say all kinds of crazy
Your last
things.
promotion. You don't need to worry about it ever again.
Yeah, I just said, now you can say a bunch of crazy things.
Yeah.
Now you can be like, Carl
Did you have to do the
Tudor,
normal?
we're taking
technique?
it up.
Did you have to do the normal technique?
Yeah.
Yeah, we are on mic here.
It's called.
Okay.
Yeah, we can hear you. And we
Yes,
have,
we can hear you.
Optional reviews, it's reviewed at the university level. But OSU reviews like promotions in 10 years is like decisions.
I don't think everyone is back yet online.
So academic, yeah, see, pharmacy.
EBGS report is up.
Academics, it's like, you have to do all this research and prove it.
There's Linnea.
Okay. Similar, okay.
Hey, Ariel,
So we have everyone back in the room. Do we have everyone back online?
I don't believe so.
Larry.
Let's
And
do a roll call. Let's see.
And Mark.
Linnea's there.
I'm here.
Mark is here. Larry's
Leslie?
here.
Here.
What about Leslie?
Leslie.
I'm
sent you-
here.
Yay, we're all here.
Again, I'm here.
Okay. I'll just say thank you for sticking with us. We've added an additional meeting this summer because of how much work is coming through the benefits update project. You're going to see benefit updates. We'll go as far as we can until 4:30. I know sometimes we finished early. It is June and probably people are seeing the sunshine. So I'll just say thank you for people hanging out for another 27 minutes. So with that, I will punt it over for the EGBS subcommittee report.
All right, the first one comes that's coming from EBGS is viral warts. And the proposal that was brought by staff to the EBGS meeting was to cover viral warts under certain circumstances. The group felt, though, that these are not cancerous, that they should only be allowed, treatment should only be allowed by exception for things like cryotherapy, and that in general, these don't need treatment. And so the recommendation from EBGS is to allow only evaluation and medical management for viral warts and musculosum contagiosum, which is a similar condition. However, they did feel that plantar warts, which are warts on the bottom of the foot, can be very painful and make walking difficult. They felt that those should be treated, and they recommended placing those on the same line as anogenital viral warts, and adding that to the code grouping title. You got to go down go down to the end and just kind of show the, yeah.
Just covering them without any discussion of effect on function or anything? So no guideline, no, just putting that diagnosis as covered?
So for plantar warts,
Yeah.
we currently cover anogenital warts. It would add
Yeah.
coverage for plantar warts with no restrictions. And there would be no treatment other than, I guess, topical medications or, other advice for the other kinds of viral warts.
A plantar would cover cryotherapy or your excision or whatever.
Right. That is the EBGS recommendation. Obviously, you all can weigh in on that.
I mean, my impression is not all plantar warts are significantly symptomatic and can respond to other conservative treatment prior to more aggressive treatment. And it's a very common condition. I would think that we would put some limitations on that appropriate to reflecting impact on function.
We could say something about plantar warts that they have to impair physical function.
I mean, isn't this
I think the EBGS kind of felt that people don't normally want treatment for plantar warts unless they're having symptoms.
And there's a lot of people that come in with things on their feet that just say, this is ugly, I don't like it, or what is this thing? And then if a clinician just says, oh, I can treat it with this thing, okay, they're gonna say no. So I would kind of think putting some limit on it, because it can be, a lot of them can be treated with free, if not over the counter things, depending on length and tolerability, et cetera. But if nobody else feels that way, then again, I am a singular person.
No, I feel that way. I think just operationally for plantar warts, that's hard because there's so many to actually to operationalize a guideline note is really quite challenging. We have to review every one of those.
Oh, you mean if we were reviewing all of them?
Right.
I mean, to me, that's more an argument to leave it as an exception process than we just blanketly cover it process.
That would be correct. Because at the end of the day, it's challenging with a high volume type of guideline notes such as these to use them.
Yeah. I mean, that's kind of where we landed for lipomas, that it was so complex that there were so many individual scenarios that we left it. Well, and the scary stuff should just be covered because it was diagnosis for lipomas. But that was the same kind of idea, is it's so complex to put appropriate limits on it. Making a guideline note wouldn't make sense. And that's kind of what I hear we're talking about.
And what we could do, if you're concerned, is we could then just put plantar warts in the evaluation and medical management group, and basically no change from current coverage.
I think that most appropriate because a lot can be treated with those.
Does anyone disagree with that? I want to argue against it.
I do not disagree.
Ariel, this is Leslie. Can you just help me understand what is current coverage?
So currently, viral warts, musculosum, which is a wart-like condition, and plantar warts are on non-funded lines. They would have office visits covered. If there is a topical medication that is not under PA, they may get that covered, but not cryotherapy or excision or a medication that would need a PA.
Have a clinical question just to see what is the current so I know that there's a current kind of topical thing that seems to be really well.
I mean, you can use salicylic acid pads, then.
Well, yeah, I've gone through that kind of stuff. So some
it's
families,
an elongated process.
Some families get recurrent stuff, because it's contagious, and there's some people just get it all the time. So, but the newer kind of stuff, which is kind of it makes your own immune system go after it. That's it's a biologic. So that salve kind of stuff is amazing, and I'm just wondering what are the chances that that doesn't work? I mean, so if you have a plantar wart, I mean, you need to get rid of it. So is this
not necessarily? There's a lot of people that tolerate them. You don't necessarily have to get rid of them.
Yeah, but they can be painful.
In the natural history of warts, as many of them actually do regress as the person's own immune system. So there are some that will go away on their own, some won't.
Yeah, and I think I'm arguing with the potential situation a patient may find themselves in where they've tried the topical stuff and it's just not working and they have a painful foot. I'm wondering, is it really, would physicians really see that they can excise something and just go for that straight away versus the topical? I would imagine that the standard of care is to go the topical route versus kind of like misuse the system. So I don't see the need for guidelines necessarily, is what I'm kind of
well, that's why I wouldn't
seeing.
We'd leave it as just covered for meds, and then if there's exceptions, they could do the more aggressive things, because that's much more common than the exception that it's really affecting function. And that it's too complex to kind of put a guideline on us, and that's when we landed back on the leave it to exceptions. It's not perfect.
So, and then the physicians would see that excision would not be covered for a plantar wart, And so they'd have to petition to have it covered.
They'd have to submit a PA and kind of write in there, you know, why it would make sense or why it's more important or specific for this person, yeah.
So what I am hearing is Max is more comfortable with leaving the coverage as is currently for those situations that are more complicated, utilizing the kind of those exception processes. I'm hearing kind of similar perspectives from Mark. Is that correct? Thumbs up. What are other people?
That is correct.
Where are other people? It seems like Lisa, you're maybe.
I just got a clarification. I think with the expertise of the room, I feel a little better about it.
It's not a perfect system.
Yeah.
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 So essentially what this would be the recommendation would change. We would add all the ICD-10 codes that you see there to evaluation and management, and we would not change the code grouping title for the intergenital viral warts. Is that what you folks want to do?
Say that again, Ariel, or I think we're waiting for it to come up on the screen.
It's just, yeah.
Liz is changing it. So we would add all of the ICD-10 codes in this to evaluation and medical management, and that would be the only change.
Can I ask a different question? Up above it says P&T, you're looking at meds for molluscum contagiosum, but if we don't fund it, how do those interact?
So there will be no unfunded region.
Okay.
So P&T will need to review it.
They're just talking about that for.
And if there's an FDA indication or
Okay.
supported by compendia.
Okay.
They can get it,
Okay.
non-evaluated.
But it could be step through.
So that's just for above stuff, that's not before.
Right.
Okay.
Yeah, I'm sure they have done reviews about topical wart treatments at some point. But they will as well, because these will be medically covered. So the medications would need at least to have some sort of PA criteria.
So maybe since we are short on time, and just to be clear where we finished and where we ended, maybe we'll take these, we'll vote like item by item. Do I have a motion for what is on the screen? So it was staff recommendation as amended.
Motion to approve.
I have a motion from Max. Do I have a second?
Second.
Second from Mark. Okay. Daphne, are you back? I saw a message about stepping away, or is there something?
Daphne actually had to leave, so
Okay.
I'll go ahead and call the roll.
Okay.
Lisa Kuzas,
Yes.
Max Kaiser,
Yes.
Larry Lyon,
Yes.
Mark Buckles,
Yes.
Linnea Lindsay,
Yeah.
Leslie Sutton.
Yes.
Did I miss someone?
Adrian.
Adrian.
Yes.
Full Professor Irwin.
Full Professor Irwin.
A motion carries.
Yay. Okay, we will keep going down. We will move on to.
Paniculectomy. So currently, paniculectomy is below the funding line. Oh, I'm sorry, my computer is trying to tell me all kinds of things. I don't want you to tell me that. So for paniculectomy, this was also discussed at the April EBGS meeting. We currently have a guideline that outlines when essentially a exception could be made.
Page
So
214, sorry.
The question that EBGS looked at was, what's the evidence of effectiveness and harms? This has been discussed before, and it was felt that harms outweighed benefits, and that the updated review also, EBGS agreed with staff that it continues to show that harms outweigh benefits. However, it may be valuable in certain cases, which is where the exception process comes in. So EBGS is recommending that we only cover medical management for paniculectomy type of things, and other than for gender affirmation surgery, and that we strike the wording in the current guideline about when the procedure would be required, and we just say that it's not medically necessary due to high rate of complications. It would still be available for an exception because it would be considered not medically necessary and not excluded or outside the benefit package.
Do we have a function to retain those guideline notes when we're looking at things for exceptions? I have a question about another topic too, because we spent a fair amount of time going through those and making them. It seems helpful to retain that knowledge.
I mean, there are archived prioritized lists and staff have tons of stuff if you want to ask us.
Yeah,
I think it would be confusing to have it on the published list.
I'm wondering if there's a different, because we're kind of moving into that new paradigm, if there's a different function or place we can retain that. I mean,
So
I'm fine looking at all
how
this.
would you
Nobody
use
else
it
is.
in a DUP world? I'm actually
Exceptions.
for exceptions.
Yeah.
Yeah, I've been wondering about whether we should, in some sense, document exceptions criteria for things that would be denied by default, but so there's a transparent way of saying exceptions when X, Y, Z, but let's talk offline, Max, about that.
Okay, because I think for the pelvic pain one, that was the same idea, right? Just get rid of it.
Yeah, let's talk offline.
Questions or comments from the committee?
Again, just a quick question. Other than as part of gender affirmation surgery, again, is that a legislative imperative?
Yes, correct. It's part of the WPATH guideline.
Do I have a motion to approve if there's no other comments or questions?
I'll make a motion to approve it.
Okay, thanks, Mark.
Second.
Second, Max. Okay. You want to call Jason, or I can do it?
Yeah, I can do it. Hang on.
You're calling yourself.
All right, Mark Buckholz,
Approve.
Max,
Yes.
Lisa,
Yes.
Linnea,
Yes.
Larry,
True.
Leslie,
Yes.
Adrian,
Yes.
motion carries 7-0.
Okay. Ariel, we have 11 minutes. Is there one topic that we feel like we can cover in 11 minutes? I'll defer to you about gynecology or dermatology, or neither.
Maybe one of the hysterectomy guidelines or
Not really, it's a big one.
actually the two that we covered were the ones that were in all of the meeting materials that were published ahead of time, and so I think that's great. Maybe we can just spend the last few minutes closing up and we can deal with all of the stuff from the EBGS meeting last week in August.
Okay, that lets us finish a little bit early.
It's a reward for staying a little bit later than usual.
Just to make sure, because there were some people who had potentially come in to comment on public testimony, not on the agenda, to make sure that we don't have anybody who's here to comment.
No, she did at the beginning of the meeting.
I don't see anybody.
I don't see any hands up or anything in the Q&A.
All right, so next meeting is August 14th, same place. Anybody know they can't make it? Max is gone. Anyone else?
I might.
Lisa's unsure, okay. Well, we will be sending out an email, but we want to make sure we have a quorum. It's always a little harder in the summer, so.
I can. Yep, I can.
Okay, thank you all. Appreciate all of your time and effort.
Thank you.
Thank you.
I'm gonna use my gavel. We are done. Thank you all.
All right, I will be ending the meeting.
Thanks. Bye-bye.
Bye.